Hello everyone, in this video we are going to see about the very important topics of vocal cord palsy and carcinoma of the larynx. Okay, first we see about the where did the local cord lie. It lies in the glottic region, that is it lies between the a straight line drawn in the ventricle from the ventricle till the line drawn in the true cord. Okay, end of the true cord, it is the glottic region. It is particularly 1 centimeter in length. Okay, this vocal cord palsy occurs at this vocal cord. Okay, before going to that topic, we need to talk about very two important topics. Okay, if the vocal cords both lie very closely, that is between like this. Okay, this two lie very close, it the breathing is affected, but the voice is normal due to the both touching of the vocal cords. Okay, but in this is adducted position, but in abducted position both the vocal cords are open, very large gap is there. Okay, very large gap is there means the breathing will be normal but voice will not be produced due to the non touching of the vocal cord. Okay, this is about the cord topic. Then we see about the nerve supply you want to know. Okay, this vocal cord is supplied by mainly two nerves. Okay, first is the vagus nerve, 10th nerve, which gives branches like superior laryngeal nerve and recurrent laryngeal nerve. This recurrent laryngeal nerve divides into right and left. Okay, this right goes and turns from the subclavian artery, this left goes and turns from the arch of aorta. Okay, this both supplies the vocal cord. Then also this superior laryngeal nerve gives a branch known as external laryngeal nerve, which supplies the only one muscle known as cricothyroid muscle. Then remaining all muscles are supplied by the recurrent laryngeal nerve. Okay, then let's go into the topic. Okay, then see the okay, most common nerve injured during total thyroidectomy is external laryngeal nerve. Okay, it lies very superficially in the thyroid. Okay, then then we want to see about the Simon's law, about how this recurrent laryngeal nerve damage occurs. Okay, he said that in case of any progressive neurologic disorder like myasthenia gravis, like that, the abductor fibers of recurrent laryngeal nerve are the first to be affected. Okay, because they are phylogenetically new. Okay, see, this recurrent laryngeal nerve gives two fibers, adductor and abductor fibers. Okay, this adductor fibers involved in the prevention of airways, whereas abductor is involved in the newer function like voice production. Okay, so this prevention of airway is the most important and is considered as a old function. Okay, so he said that first affected is the newer function, that is not needed function. So this abductor, he said this law, but this law is most common not accepted. Then there came the Wagner's and Grossman hypothesis. He said all muscles are causing adduction in larynx. Okay, then in recurrent laryngeal nerve palsy undergo palsy except cricothyroid, which is supplied by external laryngeal nerve, which is the reason for unopposed adduction. Okay, median position, adduction position is the median position. Okay, this is the most accepted law. He said that during this recurrent nerve palsy, the abduction is lost. Okay, but the cricothyroid is there, which is main function is adduction. Okay, so adduction will be there, unopposed adduction, as he said. Then let's see about the normal vocal cord position. It is see, this position is known as the median position. This is adducted position. Then when lightly outwards, you come in the paramedian position. Then again lightly outwards, you come the intermediate position. From there you can go to the intermediate position is also known as cadaveric position. When there is no supply to the vocal cord, both adduction and abduction is lost, then this intermediate will appear. Then the slight abduction. Okay, then full abduction. This condition will come when the adduction fibers are lost, only abduction is there. Okay, but this condition will not occur anywhere. Okay, then firstly see about the unilateral external lobe palsy. Okay, laryngeal palsy. As we seen earlier, the external laryngeal nerve is only supplying the cricothyroid muscle, which function is both adduction and tensor, okay. But the one, if adduction of this muscle is lost, the adduction of all intrinsic muscle is there, okay, then no problem. Then this tensor also, it is one is the tensor of the vocal cord, it increases the length. So this increase in length is needed for a high pitched voice. So in this palsy there is a problem of production of high pitched voice, okay, but it goes unnoticed as is not required, okay, like men, okay. Then if bilateral external palsy is there, this also can go unnoticed, but if you're trying to produce severe high pitched sound, it will create a problem for you, okay. Singers, if you have the singers, it's a drastic condition for them. Then let's come to the unilateral recurrent low nerve palsy. The left one is the more common, okay, because it goes to a large distance, covers the arch of aorta, okay. When this injury is there, okay, everything injury you should draw a map like this, okay. Unilateral recurrent nerve palsy, okay. Abduction is there, adduction is there. Here due to the cricoarytena muscle is the only abductor, so abduction is lost. Then all intrinsic muscles which cause adduction is lost, only cricothyroid is there which causes adduction, so it can't cause full abduction, as all muscle working requires the all muscle worked, it only cause the full adduction, so it comes paramedian position. So like this will come like this, paramedian position, but other is working normally, okay. So there will be hoarseness of voice, okay. Airway is good because of a large gap, okay. But due to this will come and touch and go. This alternate, this also will become hypertrophied. The compensated hypertrophy of the other vocal fold in very few months. Then voice width will improve, okay. Then voice also will improve. This hoarseness will disappear. So this is known as transient hoarseness, okay. Next we dive into other topic like bilateral recurrent nerve palsy. You have seen this unilateral. Then let's dive into the bilateral recurrent nerve palsy, okay. Here also draw the map, adduction and abduction. Here also abduction is lost, then intrinsic muscle lost, only cricothyroid is there, so both both vocal cord in paramedian position, okay. So when both in paramedian position, here the respiratory gap or breathing air is very low, only 2 to 3 millimeter air is gap, but voice is good because the less gap of folds can meet and voice can produce it, okay. There will be strider, okay, very small gap. Whenever there is a very small gap in the tractor airway, there comes a strider, okay. Here what you need to do is you need to increase the air, which is the primary most function. So you need to go for type 2 laryngoplasty or lateralization thyroplasty, okay. I'll explain here. Wait, see, this is the type 2 thyroplasty, where you are cutting open the thyroid cartilage and expanding it, so that both the vocal fold which are in very close here, they can go apart, okay, slightly apart, so the breathing can be improved. So they are doing type 2 thyroplasty. Then there are other operations like laryngofissure, which is most commonly not done. Then Casimo's operation, where you cut a part of the vocal fold itself, okay, along with the membrane. Then there will be a large gap for the air to go, and the voice will be also normal, okay. This cutting is with the help of a CO2 laser, it creates airway. This is all about the type 2 thyroplasty. Then let's go into other conditions like puberphonia, okay. Puberphonia is nothing but male having female like voice, okay. Usually male have very low voice, but the females have very high pitch voice. If you are sitting in a library, if you male speak, that will not appear, but if a woman speak, it is very high pitch, you can hear a long distance, okay. So this type 3 thyroplasty is done for puberphonia, okay. Before doing the type 3 thyroplasty, you should do a confirmatory test, which is known as Gutzman test, okay. Male man, okay, you can remember that like that. if you press the thyroid cartilage, okay, it this, as I said earlier, this high pitched voice is due to tension of the vocal cord. So if you pressing the from the thyroid cartilage from both sides, the tension of the vocal fold decreases and will become bulkier, so the pitch decreases. So decrease tension and low pitch voice, and this is normal to male. Okay, if it's not, the test have come to be positive, then you can proceed for thyroid capacity, where you can do this. You can cut this thyroid cartilage and place insert inside, and you shall shorten the thyroid cartilage, so that the tension will be decreased, will be very decreased. Okay, for long distance is there very high tension. If you decrease the length, that will tension will be very less. Okay, this is type 3 thyroplasty. Then type 4 thyroplasty is done for females who have male like voice. Okay, androphonia, exact opposite. Here the length is less, you should increase the tension. Okay, for that what you can do is you can press this thyroid cartilage below and this cricoid cartilage above, so this causes an increased working of the cricothyroid muscle, so the vocal fold will be elongated, so vocal cord will be elongated, and this causes tension and high pitched voice for the females. Okay, that's it. Then a condition known as bilateral superior nerve palsy. Okay, go to the diagram. Superior nerve gives two branches, external and internal laryngeal. This external supplies the cricothyroid, so adduction is lost, but the other intrinsic muscle can compensate there. But what if the internal nerve which supplies to supraglottis and cuff reflex is absent? If cuff reflex is absent, if something goes into the trachea or larynx, it induces cuff reflex. So this absent means it can cause aspiration and pneumonia. The patient will be straightly come into the ICU, then only you can diagnose the condition as superior nerve palsy. Okay, so this is known as intractable aspiration. Okay, this is in this condition we can do nothing about it, so you can do tracheal separation. Okay, we should separate the trachea, and you can do permanent tracheostomy, and if the condition of the superior nerve is improved, you can again reversible, but if it's not improved, you can do permanent tracheostomy and close the larynx. Okay, this is about SL1 and palsy. Then let's come to last, unilateral recurrent palsy plus unilateral external laryngeal nerve palsy. Okay, we can commonly say this unilateral vagal nerve palsy, where supplies both come unilateral side. Okay, in this condition, see both the adduction, all muscles, everything is lost due to this supplies all muscles, this supplies only one muscle, so this everything is lost. So this will appear in cadaveric position or intermediate position. Cadaveric, normal. Okay, position, so it will appear as like both is like though. Okay, so there will be hoarseness, as this not vocal cords not touching each other. There way is good. Okay, but here it touches the paralyzed cord, so it became hypertrophy, but here it not touches, both not touches, so no compensatory hypertrophy. The gap will always be there, so there will permanent hoarseness. Okay, and also aspiration of foreign body will also present if cuff is absent. Okay, then first you can do is push the paralytic fold to medial line. Okay, you can push the both sides from medial line, so you can do manual compression test. If hoarseness improves, then you can do the surgery of type 1 ischemic thyroplasty. Okay, there are 4 types of assassin. This is the medialation thyroplasty, or this you can see lateralization there, so this is medialization that improves the voice and also the respiration be normal. Okay, and see here, see you are cutting this open and getting it slightly median position, so it will be very medial and you can come close to each other, and the normal breathing will be there, normal voice will be there. Okay, thank you guys.